Hi, I'm Jennifer, and today I'll be talking to you about eating disorders. Let's begin with some history. The earliest accounts of starvation start from the 4th century and often involve religious saints using anorexia for self-control in 1200 AD. They felt it brought them closer to God, and more medical descriptions persist until the 1900s. Sir William Gull was the first man to coin the term anorexia nervosa in his diagnoses in 1874. His patients had common symptoms of weight loss, skin changes, loss of period, dietary restrictions, but there was lack of concern for shape or weight. Likewise, Gerard Russell was the first man to coin the term bulimia nervosa. Although it's existed since the ancient Egyptians and Romans, it's also referred to as dysorexia, hyperorexia nervosa, or bulimiorexia. The DSM-5, or Diagnostic and Statistical Manual for Mental Illness, describes the different types of eating disorders. This is Ellen. She's anorexic. Anorexia nervosa includes food restriction, low body weight, fear of weight gain, disturbance of self-image, and denial of their condition. Several subtypes include restricting type, binge-purge type, and atypical AN. This is Marie. She is bulimic. Bulimia involves binging a large amount of food while losing control and then purging afterwards to compensate in ways such as vomiting, laxatives, diuretics, and more. It usually occurs once a week for 3 months. Bulimics tend to be very critical of their own body and often are of normal weight or even overweight. This is Naomi. She has binge-eating disorder. BED also involves binging a large amount of food while losing control, but unlike bulimia, there's no purging. It occurs once a week for 3 months. They eat quickly until too full and may feel depressed after. This is Tanya. She has ARFID. Avoidant-Restrictive food intake disorder is an eating disturbance where the person fails to meet nutritional needs, but not due to any lack of food, culture, or weight concern. Often they only eat certain types of food. More types include pica, eating non-nutritive substances, rumination involves regurgitation of food, or unspecified for all others. Comorbidities seen with eating disorders involve depression, OCD, anxiety, and more. Here are percentages of people that have major depressive disorder along with a certain eating disorder showing the prevalence of comorbidities. Heart problems and suicide are the top 2 reasons for death in EDs. All medical complications stem from malnutrition, which is a deficit in nutrients, a low BMI, and losing weight too quickly. Common issues include bradycardia or low heart rate, hypothermia, electrolyte loss leading to refeeding syndrome, low brain energy supply, and digestion problems. More medical issues include delay of puberty, extensive bone damage, immune suppression, swollen glands, hair loss, dry skin, acrocyanosis, aka blue limbs, and more. Some are irreversible and may require hospitalization. Culture and social media play a role in ED development according to sociocultural theory. This uses models like dual pathway and tripartite to illustrate how peers, parents, and media can influence an eating disorder. Objectification theory involves a person seeing themselves from a third-person perspective, then judging themselves. Studies showed that women seeing themselves in bikinis rather than sweaters were more likely to eat less and express body shame. Cross-cultural differences also influence ED in that cultures less exposed to Western ideals, or less acculturation, have lower ED rates. A study in Fiji showed that exposure to Western culture through television raised eating disorder rates. Let's briefly look at the underlying neurobiology. The mechanism behind eating disorders involve both the reward and inhibition circuitry. The ventral limbic circuit controls emotions of reward and pleasure as well as salience processing, whereas the dorsal cognitive circuit minimizes risk and plans for consequences. Anorexics have a higher inhibition toward eating due to the cognitive circuit, along with a decreased reward response toward food. However, bulimics have an increased reward response when fed, seen in activation of the limbic circuit. Both suggest an imbalance between the 2 circuits. Hunger normally prompts reward, but in ED, food alerts a risk signal. And that concludes this video. Thank you for watching.
Created using PowToon.